Thank you very much. I appreciate the invitation to speak with you tonight. And this week is National Infertility Awareness Week. So we'd like to communicate about infertility. It's an issue that we deal with as experts every day of the week. So when do we call a woman infertile or a couple who hasn't conceived a child? There is some information about how long it takes to have a child. And so this research is done in the 1950s and really hasn't changed much since then. So when couples are trying to have a child, when they're actively trying to conceive, about half of them conceive within the first 3 months, about 70% within the first 6 months, and about 85% conceive a child after a year. So we have to determine when is the appropriate time that couples should seek assistance. And we have a professional society, it's termed American Society of Reproductive Medicine. So they set forth some definitions. So we do use these because we use these definitions to counsel patients about when they should seek care. And so the definition for infertility, according to our society, is a disease that's kind of failure to achieve a successful pregnancy after 12 months of trying, having intercourse between the man and the woman. 12 months or 1 year. This definition, however, is modified because we think earlier evaluation is warranted if the woman is older. So for instance, if the woman is over the age of 35 years, then we think it's worth consulting a specialist after 6 months of trying. What is the incidence of infertility? In other words, in the population, and as Fartun was mentioning, it's blind to ethnicity. So in Caucasian and in African descent patients, the incidence is about the same. So about 10 to 15% of couples are affected by infertility. This means approximately 1 out of 8 couples experiences some problems. Okay, this slide, it's hard to probably read it from your chairs, but it's breaking down the causes of infertility. In other words, when is it attributable to the woman? When is it attributable to the man? When is it attributable to both? Or in what percentage of the time do we not really know? Is it attributable to the man or the woman? And what I'd have to say is that these colors on the bottom are reflecting problems that are related to the man. And sometimes I think that isn't as appreciated because, of course, the woman has the baby and carries the baby, but a lot of times the fertility problem can derive from the man to begin with. In other words, the man may not have adequate amount of sperm, adequate number of sperm. The sperm and egg have to come together to produce a baby and a child. And I'll just point that out to begin with. We usually know the cause of infertility in about 85% of the couples. So about 15% of the time we don't know. And when, like I said, when we do know, it's pretty close to almost half that are related to the man or the woman, and sometimes a problem with each. So anyway, as couples are seeking care through us or some other provider or physician, how do we counsel patients when they're preparing for pregnancy? Because when we see couples who don't have a child, they will be preparing themselves for pregnancy. So we have some general advice. I'll start with some advice for the women planning pregnancy. It's ideal if a woman is trying to achieve a normal weight. So if a woman is underweight, if she tried to gain weight, that would be advisable. If a woman is overweight, sometimes it's good to try to lose some weight. Smoking cigarettes, we would usually advise that women try to reduce or stop. Avoid other types of illicit drugs. Alcohol can be a problem as well if it's high. And we also advise women to take a vitamin supplement. And this should include what's called folic acid, and that limits certain types of birth defects, so we advise that. Sometimes that's termed a prenatal vitamin. We advise women to try to keep track of their menstrual cycles. In other words, when did one start? When did the next one start? When they are able to tell us that, we can determine if it sounds like a woman has normal cycles. There's also ways that women can do temperatures to determine if their cycles are normal. We can advise patients how to do that. There's also kits that you could pick up in a pharmacy that a woman could use to check her urine to determine if it's at the time that she's fertile or the time that she's ovulating or releasing an egg. Sometimes we advise that. How about men? For men, we also talk about trying to reduce smoking or stop smoking, avoid other recreation drugs, moderate alcohol as well. So a lot of these are just general health tips. We think it might be good for men to take a multivitamin too, because that could help their fertility potential in some cases. For men, we just advise to try to avoid hot baths, saunas, whirlpools, or high temperatures in the bath, as well as tight-fitting clothing. Okay, so if a couple comes to see us, what happens? So what happens during an infertility evaluation? Back, please. I'll just point out that there'll be a medical team, so there'll be a doctor, and a doctor has a bunch of people helping them. We have nurses, we have office staff, we have scheduling staff, laboratory staff. So a doctor needs a whole team, a medical team, to see patients. And then for an infertility evaluation, as the picture depicts, we like to see the man and the woman. Who performs infertility evaluations? Well, a gynecologist can. And a gynecologist is a specialist, a doctor that specializes in a woman's reproductive system. There's a type of specialist that's called a reproductive endocrinologist. So I am a reproductive endocrinologist. A specialist like this specializes specifically in the identification and treatment of infertility. A urologist is also a doctor that specializes in a man's reproductive system. So sometimes it's inappropriate for a man to see a urologist for a fertility problem. Okay, so what happens when patients come to the office and what do we do? We obtain a history, a medical history from both the male and the female, because we want information about both. We likely recommend testing, because there's different kinds of tests to be performed to determine what the cause of infertility is. So we do recommend testing for both the woman and the man. Some common tests, and I'll get into this a little more as the slides proceed, but some common tests are some hormone tests, blood tests of the woman, what's called a hysterosalpingogram, or an HSG, which is an X-ray of the fallopian tubes for the woman. A pelvic ultrasound or a vaginal ultrasound is another test to evaluate the woman. And there's a test to evaluate the man that's called the semen analysis. And this is looking at the man's emission, or the man's semen, to count the number of sperm and the appearance of the sperm in the semen. In certain circumstances, we do additional testing. And in certain circumstances, there are surgical procedures that are sometimes necessary for the woman, including procedures that are termed laparoscopy and hysteroscopy, which can check a woman's reproductive system. When women have some hormone tests, some of the tests that we do is trying to determine if a woman is having problems related to her age, because as a woman gets older, her fertility can decline. So some hormone tests are called ovarian reserve tests, and these are done to try to determine that. Normal results with these types of tests imply a normal number of eggs and good fertility. Abnormal results imply lower number of eggs and lower fertility. So we try to assess that. The specific hormones are called follicle-stimulating hormone, anti-Müllerian hormone. As a woman gets older, what happens? Well, unfortunately, fertility does decline, but that varies amongst women. So some women who are older, and many of you have probably heard of older women having children, but it does become more difficult. There's an increased risk of having infertility. There's also an increased risk of a pregnancy loss, or what's termed a miscarriage. So as a woman gets older, the risk of miscarriage increases. Also, there's an increased risk of having a baby with a genetic problem. If you are aware of Down syndrome, which is one type of genetic problem, that's an example. And the risk for that is increased as women are older. Also, some of our fertility treatments aren't as successful for women who are older than they are for women who are in the younger age range. So we have to evaluate several things. I'll just go through some of these things. We'll start with some of the tests for women. So we have to determine, is a woman ovulating? Ovulating means release the egg. And a woman releases an egg every month in her cycle when she's fertile. So we try to determine that. One way we do that is try to determine her menstrual cycles. I mentioned before that it's helpful to sometimes track them. So we get from the woman how often her menstrual cycles are, and we try to determine if that sounds normal. There's also the temperature charting, which I referred to. Sometimes we have women chart their temperatures every day, and we try to see if there's a change in the temperatures that suggests that the woman is ovulating. There's also the urine ovulation test that I mentioned before. So at the middle part of a woman's cycle, she could do this testing to try to determine she's ovulating. And this is an example of what could happen on a temperature chart where a woman is recording her temperature. In the early part of the cycle, the temperatures are a little bit lower. But if she did ovulate, then in the second part of the cycle, we can see the temperatures go up. So a temperature chart with a rise in temperature can sometimes be seen. So if a woman isn't ovulating, what could be the reason for that? There are conditions. I'll just mention a couple, and I won't focus on this too much. But there's a condition called polycystic ovarian syndrome, and this is relatively common. About 2 to 4% of women have it. They ovulate some months, but not others, typically. And they could have a harder time getting pregnant. Sometimes they also have problems with acne or excess hair growth on the face or the body as well. Some women have what's called amenorrhea, which they don't have any menstrual cycles. Some women have that because they're underweight. Some women have that when they really exercise a great deal. And that's another reason why women may not ovulate. The third condition is called premature ovarian failure, or what's called premature menopause. This is when a woman goes through what's termed a change of life, where her menstrual cycles aren't coming anymore. And unfortunately, if that has happened, we really don't have any real good fertility treatments for women who have experienced that. Sometimes women could consider what's called donor egg, which is receiving eggs from other women. But I know a lot of couples, and perhaps a lot of couples in the audience, may not be comfortable with that kind of means of trying to have a child. We have treatments for ovulation. So if a woman isn't ovulating, there are medications that can be taken. 2 medications are called Clomid and Letrozole, and these are medicines that they take by mouth. So they're pills that are taken. There's also what's called gonadotropin. So sometimes women take fertility medicines that are given in injection form to help them ovulate. So we have to look at other things. What other kinds of problems can happen with the woman? Well, you know, after the woman releases an egg, that the egg has to fertilize and come through the fallopian tubes. Through the fallopian tubes, the fertilized egg then implants inside the uterus or the womb. So if a woman has a blockage of the fallopian tubes, that's another type of problem. So we do have to check for that. I mentioned earlier there's an X-ray called a hysterosalpingogram where a dye test can check if the fallopian tubes are open. And there's also a surgical procedure called laparoscopy that sometimes we do in order to check the fallopian tubes. This just shows a diagram of if a woman had one of these X-rays, the dye is injected into the uterus and we could see it flowing through the fallopian tubes. Just a diagram of that. And this is just a diagram of the laparoscopy procedure, which is done in surgery, where a woman goes to sleep, is done in a same-day surgery through small incisions, where camera is inserted through the abdomen, and we look inside at the fallopian tubes. Reasons why a woman could have problems with the fallopian tubes is she could have chronic infection, and that has caused damage. She could have a prior tubal pregnancy or an ectopic pregnancy in the fallopian tube, and that could cause damage. Adhesions or scar tissue can cause damage, and a condition called endometriosis can also cause effects on the fallopian tubes. A lot of problems with the fallopian tubes can require surgery. But sometimes if there's a lot of damage to the fallopian tube, sometimes surgery is not as successful. So sometimes patients consider the treatment that's called in vitro fertilization or IVF. And Rosie's going to be talking about IVF a little bit later. When we have to evaluate the uterus, what techniques do we have for that? We have the ultrasound procedure, where an ultrasound is used to look over the uterus. Sometimes we do a special type of ultrasound, which is called sonohysterography, where we could put something in the uterus to fill it with a salt solution, so we could get a better look at the very inside of the uterus. And there's also a surgical procedure called hysteroscopy, where we can insert a camera inside the uterus as well. This is a picture of the sonohysterography, which is the ultrasound where some saline solution is in, and there's a little growth inside the uterus that we could see there. And this is just a schematic of the hysteroscopy procedure where a camera is inserted into the uterus. What kind of problems are there with a woman's uterus? There could be growths, polyps, or just growths that occur on the inside of the uterus, scar tissue. There could be septations or little walls on the inside of the uterus that have formed, or uterine fibroids. This is a very common condition. These are tumors that come from the wall of the uterus, and they can grow and start to cause problems. When we have to treat a uterine problem, it usually also requires some form of surgery to correct that. Okay, so we'll shift over to men, and how do we check men, and what happens there? We do a procedure called semen analysis, so we ask men to produce their sperm. We know that sometimes men are uncomfortable with that, so we try to find ways to help with that. Men sometimes could collect at home if they don't live too far and bring the sample to us, or sometimes they could try to collect this type of sample in our office in the clinic. Once we have the sample to look at, they're looking at the number of sperm. They're looking at motility, which is the percentage of the sperm that are moving. They're looking at morphology, which is the determination of the shapes of the sperm. And there's the criteria for each of these to determine if it's normal. And for men, there's a lot of things that could be affecting them. that is impacting their fertility. And this is just a list. And I won't go through every aspect of every one of these conditions, but just to know that there's a lot of problems that men can have that can impact their fertility. They can have injuries, they could have surgeries that affect them, they could have exposure to different medicines or radiation, toxins, etc. Men can have problems with what's called the ejaculation. That means emission of the sperm. That could not work, or it could actually go in the wrong direction, called retrograde. Sometimes men, in their reproductive tract, there's blockages. So men could have blockages where the sperm can't travel through. There's also hormone problems men can have. And there's a condition called varicocele, which is a dilated vein that happens in the scrotum that can affect men's fertility. So I just mentioned that there's a whole host of things that men can experience as well. When men are treated, sometimes if we know what the specific problem is, we'll make a recommendation. And if a man is treated and there's a specific problem that has to be corrected, sometimes we do use a urologist. So I mentioned earlier that a urologist who's a male fertility specialist might help us. They can do different surgeries when it's needed. They could do different medical treatments when it's needed, and they could assist a lot of men. Sometimes there's just general treatments that are trying to help male infertility, where we could take the man's sperm and do what's called artificial insemination. This is where we inject the sperm into the uterus and try to help conceive a pregnancy. Then there's the second technique, which we're going to talk about, called in vitro fertilization, or IVF. And this is an important treatment because this is one of our most successful treatments. But I'm gonna let Rosie kind of describe that a little bit more for you. Insemination using donor sperm, this is sometimes considered, but like I mentioned earlier, a lot of couples may not prefer the use of sperm from another man for their treatment. But there are sperm banks that do provide sperm for women if they wish to consider that type of treatment. This is just a diagram of how artificial insemination works, where a sperm sample, when it's prepared and processed and ready, is placed inside a woman's womb. So in general, what can we say about infertility treatment? We can tell you that it's not a guarantee. So if a couple sees us, we try everything we can to determine the costs. We try what we can to recommend appropriate treatment for the cause that we've identified, but it's not a guarantee that it will result in a child. However, there are many successful couples. So many couples do succeed with this. It requires the active participation of both the man and the woman. Many couples require multiple treatments, so sometimes they have a treatment. If it doesn't succeed, we might have to repeat the treatment, and sometimes we have to repeat treatment several times. And it also requires a significant amount of time to undergo the medical assessment, the evaluation, as well as all the components of the treatment. If you have infertility, what are some things to think about? And what are some questions to ask your doctor or your medical provider? One thing to ask is, what is the reason or reasons that I cannot conceive? What does the medical team think about that? What is the prognosis that the fertility treatment recommended will be successful? In other words, what is the estimated chances that treatment will succeed? What are the costs of the fertility treatment? Sometimes we have to discuss costs with our patients. And does the insurance company, if you have insurance company, do they cover the cost of specific infertility treatments? Because sometimes they do, and sometimes they may not. So that's another important question. This slide, I know you can't read it, but I just wanted to show in our clinic composition of all the people that help the doctors with patients with infertility. We have 2 doctors currently, but we have a 3rd doctor joining in August, a woman. There's also a nursing staff, laboratory staff, and a lot of people that we have to assist our couples. And our goal, and we wish this would happen, is that at the end, our patients have a
So we're trying to respect the culture and also respect the religion, but it's evident that we have to talk about it. It's a way of preventing, but it's also a new culture that we need to learn. So it's better to know how to prevent or how to protect than being in denial and say, you know, we're Muslim, we're not going to do this, and be on the edge. So purpose of Isuroon is to open the doors for opportunities while respecting our culture and our faith. So thank you so much. I have so many questions to ask Dr. Demario, and I'm going to try and take the most frequent one that have been asked. Dr. Kanit su'aalaha gabdhaha soo weydiiyeen iyo wiilashaan weydiinayaan dan hadhowtidiya turjubina. One of the things that I heard is that fear of IVF. So it's like if my husband comes and gives his sperm, I may get a sperm from a white person or African American or a Hispanic person. Can you talk about how when the husbands or the men give their sperm, how is that protected, and make sure that the right person gives the right sperm? Thank you.
Well, this is obviously something that has to be managed very, very carefully. It is true that in these instances where we are doing in vitro fertilization, the sperm is out of the body, the eggs are out of the body, so we definitely have to have the right sperm with the right eggs at all times. And so when a man is doing the sperm sample, for instance, if he brings it from home, we do very careful identification. So sometimes men forget that, but they need their driver's license or their form of ID. And we have to see for sure that is the man that is attesting to that sample. Everything is very carefully labeled. And so it's stored in very careful systems. Even when we are freezing sperm, if we are, that's in very certain designated containers that are also very carefully labeled. When a woman is doing her part and we are retrieving the eggs, we check her identification same way. We confirm with the embryologist who the patient is. We actually do that with the patient while the patient's still awake. And then the eggs are out of the body, and then that's very carefully labeled too. So all the dishes are in certain places of the incubator, and we are as careful as we can about that, all those procedures.
Thank you. Dhakhtarka waxaan weydiiyey markii la isku beerayo gabdhahan iyo wiilashan waxay ka baqaan in nin Islaam isbeerkiisa ama gabar ukunteeda qof lagu talaalo Soomaaliya. Marka waxaan ku yiri see u sameeysiin oo u hubisiin si qofka wixiis qof Islaam wixiis aan gabar lagu beerin. Marka su'aashu ka jawaab waxaad waa ilaalinaa nambaradan ku dhijinaa qofka nimanka markay keenaan spermkooda shahaadadoodii in driver license-koodii waxooda inay keenaan si loo ilaaliyo, laakiin wuxuu yiri waa ka taxadarnaa. Su'aasha kale oo raba inaan weydiiyo waxa weeyaan gabdho badan oo Soomaaliya waxay ka cabtaan in ay hormoonkooda ziyaado yahay, laakiin cabsida ay ka qabaan inay uur yeeshaan dartood marka lagu yiraahdo hormoonkaaga wuu kacsan yahay oo islama sinna marka ugxamaaga aad ma noqonayo, still waxay isku dayaan inay qasab uur ku yeesho because walaaci yahaayo. Su'aasha marka weydiinayo waxa weeye haddii hormoonku ziyaado yahay maxaa samaysiin oo aad caadi uga dhigtiin? The other question that I wanted to ask that I got I'm kind of a bias, so I'm asking all the questions from the sisters, is that a lot of the women that we help have like their hormonal is imbalanced. So some of them would say, I didn't get period 6 months, some would say 5 months, but they're still determined to get pregnant. And if you may tell them your hormone is not normal, you have to go through some sort of a period of waiting to balance your hormone, they're still determined not to go through this process. What kind of advice would you give those women who have their hormone is imbalanced but yet don't want to listen? Thank you.
Well, I think, there are examples of women having an imbalance and then having some menstrual cycles. So they may miss a couple cycles in a row and then they'll have a menstrual cycle. Well, they may ovulate, and they possibly could get pregnant even in the month that they ovulate. But the problem that they face is they ovulate or release an egg less frequently than other patients who ovulate each successive month. And so it's possible that sometimes patients with those kinds of problems can still achieve pregnancy, but they're facing a more of a challenge. Basically, if a period of time goes by, if they are irregular and they haven't gotten pregnant, then we would encourage them to seek assistance because we can treat many ovulation problems. Then sometimes we also don't know if somebody has a irregular cycle, if there's other hormone imbalances too, because sometimes other health conditions could be occurring. And so sometimes it still is worth to have a checkup if the menstrual cycles are not regular.
The last question I want to ask you about the female side is a lot of like their tubes are clogged, whether through the circumcision, infection, through some sort of whatever happened, ectopic pregnancies, and they go through surgeries. And sometimes surgery does not guarantee that the fallopian tubes will be open. So what advice would you give a woman who has fallopian tubes that are blocked, and she's like maybe 30 or she's going to 35? What kind of advice would you give instead of trying to have surgery and take a chance of the fallopian tubes being opened? What kind of advice would you give so then they can do, what is the quickest way? Actually, that's the question that women ask. What is the quickest way to get pregnant?
Yes, and so one of the main aspects of this is that there's different degrees of damage that we could determine if the fallopian tubes are blocked. Two different ways that we appraise that is through the X-ray or the hysterosalpingogram, also the laparoscopy, which is the surgical procedure. Basically, if the fallopian tubes are blocked and we think that there still is some indications that behind the blockage is still a relatively healthy fallopian tube, then we believe that surgery would be more worthwhile because the results are better. And so sometimes we see this in terms of characteristics on the X-ray, that we could see a pattern that still looks fairly healthy, but it still is blocked. Also, when the fallopian tube is more damaged, it dilates. And the more it dilates, the worse chances we have with the surgery. So in the better cases, the surgery might be in order of about 60 to 70% chance for conception. But in the worst cases, it might have only about a 10 or 15% chance. So it's those patients who have a lower chance that maybe that's not the best thing to do, where surgery's chance to have a child is lower. Sometimes those patients consider the IVF treatment as an alternative.
The last question is for the male. Last year, 2012, when we started Isuroon, everyone thought we were only for women. We're a reproductive health women organization, but that doesn't mean we're not concerned about male reproductive health issues. So last year and this year, I've got men were calling from Somalia, but also around this state that they have pluggage. I don't know what the terminology is. I think I forgot it, but they cannot ejaculate. So their sperm goes back to their kidney, and they're unable to conceive that way. What procedure do you do to get their sperm out and maybe inseminate, because inseminate the egg, or they maybe end up doing IVF? I just want to explain to Somali. Su-aashaan weydiiye waxay tahay wiilal badan oo Soomaaliya jiraan oo cudur kaga dhacay xaniyaha ama wax ku dhaceen oon ka imaanaynin miinada aysan ka imaanaynin, marka uur gabadhi ma u yeeli karaan? Su-aashaan weydiiyaa waxay tahay maxay ka sameyn ninkaas Soomaalida, maxay ma camaliyu sameyn karaa si uu spermadiisa loo soo bixin karaa si uu gabadha uur ugu yeesho? Please answer. Thanks.
Yes, and so there are some problems with men, and we're discussing issues where a man does not, the emission doesn't occur properly, so the sperm doesn't come out, and sometimes it can go backwards. It goes backwards into the bladder is where the sperm goes. And so in those instances, we may have the man see a urologist, because sometimes a urologist can help. In some instances, there's medicines the man can take, and that sometimes that helps that. So sometimes a urologist will prescribe a medicine, and the emission, instead of going backwards, can be some medical treatments can sometimes help that. If medical treatments can't help that, then sometimes we're able to get the sperm. The way that works is a man will have emission, but it goes backwards into the bladder, and we could have them empty the bladder and actually collect the sperm. So that's called a retrograde, which means the sperm is going backwards, and we do collect urine and try to take the sperm out of it. In some instances, if we collect enough sperm, we can use artificial insemination. But a lot of those instances, we may not collect a large number of sperm. So sometimes we have to use sperm in an IVF treatment or something like that. So those are some things.